Can you see my slides?
Yeah.
Yeah.
Make it
Now
full.
just go to full screen.
In this full screen. Do you see it?
No. Not
No.
full.
Okay, give me 1 second. What about now?
Yeah,
Yes.
that's right.
Okay, perfect.
Now
Sorry
move and
about
see.
that.
Yeah, that's
Yeah.
good.
Great. Great.
Okay, great. So these are my disclosures, not relevant to this lecture. Brown syndrome, I call it paradigm. Why? Because a lot of attention is being given to this old procedure, but now going to be published in the Journal of APOS with a wonderful paper that is coming from Spain, and is what is called the superior oblique thinning procedure. So I'm just going to describe what I have learned from this procedure. First is repeat this forced duction testing in a deduction in elevation until it's free. After that, is to capture the nasal portion of the superior oblique tendon and put a traction test to expose the posterior thickening part of the superior oblique that is posterior to the trochlea. At that point, this thickening portion comes anterior to the trochlea. After that, then the procedure continues by thinning the procedure. Some people call sharpening, some people call thinning. But this is what I want to kind of emphasize about this procedure. This procedure, to me, changed how I manage Brown syndrome, because not all Brown syndromes are patients that have a short or tight superior oblique tendon. Some patients have a thickened superior oblique. And if this posterior to the trochlea superior oblique is not thin, then it will never slide through the trochlea to improve the elevation in a deduction. This is not a new technique. It was first described in South America by Paulo Horta Barbosa in Brazil, and it's been popularized, but it's never really put or given too much attention of what is the importance of a procedure that can actually improve the elevation by removing some tissue that is abnormal. We're doing a study at Duke University now where we are looking the microscopic pathology of these specimens, and we have found something very interesting with an increased amount of aminoglycosides inside these nodules. So it's very interesting because I believe it's changed how I manage patients with Brown syndrome. What about managing excitotropia? So I was a person who always loved to do Harada-Ito procedures for patients that have a lot of torsion. And a few years back, we described this procedure that was a modification of a procedure that was actually presented by a group from Germany and another group from Iran. But what is behind this? Well, this is from an old paper from Alan Scott. And this paper, that was really an abstract, described how the fibers of the superior oblique not only are torsional, anterior or posterior, we actually see that there's torsion from all superior oblique fibers. This is in primary position, and this is in down gaze. Well, the interesting is that you see that most of the torsion from the anterior fibers is really in primary position. When we look in down gaze, there's actually a lot of a spread of torsional effect among all fibers from the superior oblique. So by saying this, we start working on this procedure that we call the anterior tuck. And you probably have seen it or read about it, but we just put it together a paper where we look at long-term results of tucking just the anterior fibers of the superior oblique. It's a procedure that honestly requires minimum time, is not that invasive, and if it doesn't work, you can always go back and redo it or even convert the procedure into a Harada-Ito procedure because you're not really detaching those fibers. We're just doing an anterior tuck. What we learn from this procedure, there you go, you just tighten those fibers. So I'm just going to show our last results from a paper that was just published. And that's the portion that is tucked. So what we learn with this procedure? This, and to me, this part is what makes more sense, is the stability of the procedure. Because with the Harada-Ito procedure, I have learned that a lot of the patients show encyclotorsion from the very beginning, but it takes more than 3 months for the procedure to be stable. More important, there is a significant decrease of the effect of the Harada-Ito as months pass by. So most of the patients take about 3 months to know what is the final result with the Hararaito procedure. And this is basically a procedure that is simple, less invasive, and shows stability from postoperative day 1. My third procedure is what I call adjusting the incomitants and preventing slippage. So for those who like to do adjustable sutures, especially when you're working on the medial and the inferior rectus muscle, we always face this problem with muscle slippage. And also, when we're doing these fatting type of operations, but you like to do adjustable sutures, so then we have this procedure that was introduced by Alan Scott as the recess resect procedure. Been doing this procedure since working with Dr. Rosenbaum at UCLA. But what I learned about this procedure is that we still see a slippage when we're treating incomitants with the recess resect in the inferior rectus muscle. So Kushner reintroduced this technique called the semi-adjustable, where basically he resets the muscle, he fixes the muscle at the desired position, and the central portion of the muscle is actually placed on an adjustable suture technique for later adjustment. So the muscle can be bunched anteriorly. And this is a good technique to decrease the chances of muscle slippage. So what I introduced to this technique was a modification. Basically, is make the same recess resect procedure described by Alan Scott, with the difference that I do double amount of recession compared to resection, and also do this semi-adjustable suture technique. So you basically can see that here. This muscle is basically recessed and resect, and the muscle is basically placed on the sclera at the desired position with these scleral passes. The muscle, as I said, was already resected the amount that I desire to maintain the alignment in the primary position. And the central portion of the muscle, which are these two sutures, are going to be at the original insertion, and they will be placed on an adjustable knot technique. So here you go, how the muscle can be advanced. Okay. The procedure can actually be done also very simple by placing a simple single suture in the middle of the muscle. So when you reattach the muscle on the sclera, you can use just a single suture right in the middle, and the muscle can be advanced. So I feel like it's really of help for those who like adjustable suture like myself. Okay. We're going to advance here. Excuse me. Near distance dissociation. I treat a lot of adults, and a lot of patients, for example, with Parkinson's disease, I found that they have problems with near deviations. So based on this concept of the compartmentalization of the extraocular muscles, I started working on doing surgeries for near and distance based on the upper and the lower pole of the medial and the lateral rectus muscles. And we published this recently in the Journal of Binocular Vision. But I have to give credits to other people who worked before me on what is called the slanted procedures. So the important for me is that I work on the medial rectus muscle lower pole to treat the near deviation, the same I do with the lower pole of the lateral rectus. And I work on the upper pole of the medial rectus and the upper pole on the lateral rectus to manage the distance deviation. This procedure, in my hands, have worked really well to treat patients with convergence insufficiency type of intermittent excitotropia. So for example, if a patient has no distance deviation, I tighten the inferior fibers of the medial rectus muscle. If I have a patient with distance deviation, I do a slanted recession of the lateral rectus muscle. In the last procedure, I want to present, I have two quick procedures. One is a complete Turner palsy. And this comes from a discussion that I had with Dr. Alan Scott, because I felt like if we move the superior oblique, not nasally, but temporally, we can actually create a force. We're basically seeing here a patient in whom the superior oblique tendon is detached, but instead of moving it nasally, as has been recommended in the past, to create basically an anchoring force, if the superior oblique tendon is placed temporally, it actually creates an abducting force. So I'm going to advance this slide because we don't have that much time. But basically what I'm doing, instead of moving the superior oblique to the medial rectus, I'm moving into the lateral rectus muscle. And when I do this procedure in combination with a tightening of the conjunctiva medially, that can be done with sutures, or like here, with fibrin glue, we can actually see, this is a patient with bilateral superior Turner palsy following a neurosurgery, and he has no motility. And following this procedure that I just described to you, you can actually see how much improvement this patient has. This is the patient fixing with the right eye. This is the patient fixing with the left eye. And very interesting, you will see that he still has abducting motility, which actually to me was one of the benefits of doing this procedure. Last, this is a procedure that I call the modified NAP procedure. We just published this paper. And I started doing this because I have patients like this one. And sorry for the picture, but he was squinting a lot and he has ptosis. But this is a patient that has monocular elevation deficiency in the left eye. He can really not elevate the left eye. And I did a resection of the lateral rectus because the medial has been recessed so many millimeters that I found was not worth it to try to do a NAP procedure. And just by resecting the lateral rectus and doing a full tendon transposition, you can see how much his elevation and hypotropia in primary position improved. The next slide, which is the last one, is actually a patient in whom I did the same procedure. Oh, I'm sorry. Well, I'm not going to go back. But that was a patient that actually had the same procedure done in the medial rectus muscle for a hypotropia and an exotropia. So if you do this procedure, I think my slides actually even stopped sharing. Is that correct? You're not seeing my slides anymore, correct?
Yes, we are not actually.
Okay, I don't